Hello everyone, welcome back. So this will be ninth video in our Whipple series, and in this much anticipated video, we will discuss about the portal vein dissection and the loop of Henle dissection, and this video is in continuation after the Kocherization. Please read the detailed disclaimer description, and these videos are meant for education purpose only, and it's not a substitute for professional training and professional advice. I hope you have already watched our previous videos in this series, that's number 1 to 8, to have a better understanding. And if not, do watch them now before joining us here. And to get an exclusive and premium access to our SD content, please download the app available for Android and iOS or join the channel membership. The link for everything is given in the description of this video. This is the same patient, a girl with SPEN, about which we have already discussed. So I am sharing short clip from the previous video for the description of the CT findings and the clinical case details. So this is the same patient, the girl with SPEN in head of pancreas, which we have discussed in our Kocherization and chevron incision. So this 22-year-old girl had a large mass SPEN, solid pseudopapillary epithelial neoplasm in the head of pancreas. And these are the axial images in the portal venous phase, and the tumor, SPEN, the portal vein, the splenic vein has been marked. So why we are sharing these pics here, that you understand that this large tumor, which is occupying the whole head of pancreas and the uncinate, it was pushing the portal vein, the SMB, the portal vein SMB conference, and the vein was draping around the tumor, as you can understand, as marked by the arrows. So in the preoperative planning, we had a doubt that this girl may require a portal vein dissection. So accordingly, we were prepared to do the portal vein dissection in this patient, but luckily we could save the portal vein and it got separated from the tumor. Another thing which you have to understand from these images is that there is no dilatation of the system, because the SPEN, it does not arise from the epithelium, so it is pseudoepithelial, and there is no dilatation of this pancreatic duct and the CBD. There is no HBRD. The pancreas is looking absolutely soft, very well maintained lobulation, and this draping around the tumor of the vein is even better seen in the sagittal image. So we have shared the reports also, and here you can see that there is no system dilatation. The tumor was abutting the SMB, the portal vein. So in this case, we were planning to do the pancreaticoduodenectomy, that we have kept our mind ready that the system is undilated, so we may require to do the PG. All of you can read some of these important papers about the pancreaticoduodenectomy. A paper by Sir Cameron, Experience of 1,000 Whipples, and answered by Strasbourg. So do remember that we are standing on the shoulders of the giants, and before that also Sir Alan Oldfather Whipple, Sir Halstead, who did first surgery for the periamplar tumor back in 1869. Patient in supine position with the right arm tucked. So the Kocherization has already been done. Cocker maneuver is continued to the left border of the aorta, that is the extended Kocherization, and about which we have shared 2 videos before. So mobilize the duodenum and head of pancreas of the IVC in cephalad direction, thereby removing all soft tissue anterior to the IVC. We have divided this video in 6 parts, basically 9.1 to 9.6 for the ease of watching. So in this first part, we will talk about the right to left medial visceral rotation and dissection of the right mesocolon, cattle brush maneuver. The right mesocolon is dissected off the D2 and D3 part and head of pancreas. And in this process, SMB is identified early in dissection with the gastrocolic trunk of Henle. So basically, first part after the Kocherization will be identification of the SMB, that will be the infrapancreatic SMB from the right approach. So the trick of trade for you guys is that right mesocolon is separated from the uncinate mesocolic groove. Remember this. So we are basically lifting the mesocolon of the uncinate and mesocolic groove, and as you lift it just below at the junction at the D3 part, you will encounter the SMB. And now This will be the second, and in this part 9.2, we will discuss about the how to dissect the right gastrocolic vein, how to enter the lesser sac, and the dissection of the GCT, that is the gastrocolic trunk of the Henle. And I will showcase how to identify the fusion fascia as the video will progress. So now, trick of the trade for you guys is that you stay outside the right gastrocolic vein. You can write down these things, or you can take a snapshot or screenshot of this thing and add to your library. So stay outside the right gastrocolic vein between the omentum and the vein. Use this as a key dissection plane. The omentum is left with the transverse colon, and this allows for a less bulk in the lesser sac dissection. Another trick of trade is that if you're not able to identify the SMB from the right approach above the D3 part, then if you follow the right gastrocolic vein as a landmark, it goes to the formation of gastrocolic trunk and to form the gastrocolic trunk of Henle, and which drains into the SMB. So this is the another way that you can identify the SMB, specifically if there is an involvement of vein. So these are the small tricks or trades which will be helpful for you while doing the surgery. So now, coming to the third part, that is 9.3 of this video. Now we will lift the omentum and the transverse colon. Basically, we will lift the omentum off the transverse colon. Again, this is a very helpful trick. The gastrocolic trunk of Henle, abbreviated as GCT, it drains stomach, colon, and pancreas into SMB. So three structures, the venous drainage is make a confluence from the GCT and drain into the SMB. There are basically three constant tributaries and variable contribution from the fourth. So first is right gastrocolic vein, then the ASPDB, which drains head of pancreas and duodenum, superior right colic vein or the right colic vein, and the first jejunal vein will have a variable contribution. And in this patient, I have also shown the anterior inferior pancreaticoduodenal vein, that is AIPDB, drain into the GCT. The importance of this dissection and configuration cannot be overemphasized. You must identify this structure, stay ahead, dissect it properly, and take a proper control. Otherwise, you can very well amaze that if there is an injury, you will be having bleeding from the SMB side, from the right gastrocolic, the ASPDB, AIPDB, right colic vein, and it is a mess and very difficult to manage. Do remember that this is one of the variable anatomy. There is no one thing which is common. There may not be any GCT. All these drains independently into the SMB. The first jejunal vein may have a connection, or it may drain into the SMB very close to a GCT trunk, and there is a possibility of injury by looping it. Fifth part of this video, that is the second last part. In this, we will dissect the GCT, dissect the infrapancreatic SMB. So this will be the part 6, 9.6 part of this video. In this part, after ligation of the GCT, we are trying to create the tunnel of love and dissecting the infrapancreatic part of the SMB. So, what is tunnel of love? It is informal but widely used term among pancreatic surgeons. I hope many of you have already heard about it, to describe a dissection plane encountered during the Whipple procedure, the tunnel of love. So, what is the location and surgical context? So, this tunnel refers to the narrow space between the pancreatic neck and the superior mesenteric vein, portal vein confluence. This is called tunnel of love. It is dissected to free the pancreatic neck from SMB portal vein confluence, allowing safe transaction of the pancreas. The name tunnel of love humorously reflects the precise, meticulous dissection required to avoid venous injury, as injuring the SMB portal vein confluence can lead to catastrophic bleeding and you may have to abandon. So, if you can clear the tunnel of love, then there's another implication is that the vein is free most of the time. You can proceed with the surgery. If you have a difficulty, like in this case, there was more than 2/3 compression of the maybe more than 75% part of the vein was compressed by the tumor. So we were worried. So if you fail to clear the tunnel of love, then your difficulty. So with that, we have reached the end of this video, friends. So in the next part of this series, that will be video number 10, we will share the tricks of trade of the suprapancreatic portal vein dissection and hepatoduodenal ligament dissection. And in this patient, there was difficulty, so that will be more interesting to watch. Don't forget to like, subscribe, and hit the bell icon to stay updated on our surgical training series. Do share this channel, our app, with your surgical colleagues. You can download our app or join the channel membership for exclusive and early access to the premium high definition content. And do watch all the previous videos in this series. I'm sharing the cards of the previous videos, and all these videos are available on our YouTube and app. So thank you very much, friends. I hope I was able to add some new insight to your knowledge. These are very complicated procedures. You should practice among the supervision of your teachers or seniors, and steadily, slowly, you will gain competence. And I hope these videos will give you some baseline knowledge, baseline confidence to accomplish these very complicated procedures with success. Thank you very much. Stay tuned. Happy learning.